to really start by going through some of the objectives, which is to really to try and apply these common dysfunctional patterns of cortisol to how patients are going to present, because patients aren't going to come in and say, well, some might, I suffer from adrenal dysfunction. They're going to come in with lots of different symptoms that have been associated with different stages of adrenal dysfunction or HPA axis dysfunction. And I'll be using those terms interchangeably, but whenever I say adrenal dysfunction, I'm really talking about hypothalamic pituitary adrenal dysfunction. So I wanted you to get an idea of some of those pathophysiologies that are associated with the different stages of adrenal dysfunction. And to me, it makes it a lot easier if we divide things into high and low cortisol presentations, but we'll go through that individually. And then I want to sort of leave you with this systematic approach that you can use to address patients. And a lot of that has been already discussed in the pre-on-site lecture. So I really, really hope that if you haven't listened to it, I encourage you to listen to it. And by the way, just a quick show of hands on the chat. Can you tell me how many of you have already listened to that pre-on-site lecture? Well, thank you for doing that. And for those of you that haven't, I really encourage you to, because there's a lot of information I couldn't cover here that is covered there, particularly when you're looking at history and physical exam. I went through laboratory evaluations there as well. I'll be mentioning it briefly here because I really want to focus on the treatment. And I want to just set the stage with this email that I received from one of you a couple years ago. And it says, I'm especially interested in the relationships between female hormones and mood disorders, as this seems to affect most women across the board at some point in their life, and many get medicated for bipolar or depression when it's really hormone imbalance. I just had 2 friends commit suicide this spring, both women in their early 50s, postmenopausal, one with depression that got worse as her hormones changed, and one that had depression that manifested as bipolar as she went through menopause. Both had healthy diets, did yoga, had a spiritual practice, and lots of community/friends. But the inner battle became too much. I just know there's a connection here we have to pay closer attention to in order to support women and even save lives. If there's any way to share this request with the speakers in advance so they might consider addressing it, I'd love that. So what I did is I adjusted my presentation based on this and did quite a bit of focusing on patient presentations that are associated with HPA axis imbalance or HPA axis dysfunction, adrenal dysfunction. And to begin with, I want you just to get an idea about the 24-hour periodicity of corticotropic activity, and that it's really controlled by the circadian rhythm that we have throughout life. And although when we look at a 4-point or a 6-point HPA axis or cortisol curve, we often are really only looking at what is happening during the day. I want you to, in the back of your mind, have that idea what exactly is going through, right? So if we're peaking as we wake up in the morning and we're decreasing it throughout the day, that being a normal cortisol curve, think about what happens since it's rhythmic when it starts to increase. So usually around 3 to 4 a.m., it will begin to increase, but it's really the act of awakening that causes that cortisol awakening response, right? So that it peaks just through the act of awakening, and it will peak 45 minutes after you wake up, within the first 30 to 45 minutes. Now, for those of you who did the pre-on-site lecture, you're going to whiz through these, the next mini cases I'm going to do. And for those of you that didn't, you can always go back and review. But what I'm going to do is I'm going to show you a case. I'm going to give you the characteristics of a case and then show you a graphic of the cortisol curve and have you associate each case with what graphic. And in some of the cases, you may use, the answer may be more than one, and I'd like you to do both. So let's just start with the first one. And please try to not look ahead at the answer, but try to just test your knowledge. This is here to help you establish how well are you doing and what do you need to work on. So this is someone who presents to you complaining of having trouble with sleep. And the main complaint is difficulty getting to sleep and having easy awakening. So let's look at these 6 responses and see which one do you think it's most associated with. I'm going to give you just a few seconds. So again, trouble getting to sleep and easy awakening. So the most likely answer would be D, where you see the cortisol curve is increasing in the evening. Case number 2. This is trouble with sleep, but now it's difficulty staying asleep. They may wake throughout the night and they may have early morning awakening, but there's no trouble falling asleep or getting to sleep. So see, which one of these would you say that's the problem, or that is most likely associated with? So in this case, the answer is B. So it's someone that in the evening, the cortisol is normal, so they're able to fall asleep, but they don't sleep well. They wake up early and several times during the night, which means their cortisol is most likely peaking early, and B would be the most likely answer. Mini case 3. This is someone that is tired or groggy in the morning. They may have difficulty waking up and difficulty starting into the day, but they may feel a little bit better later on during the day. Which one would you say this is associated with? So the best answer would be A, where you have flattening of the cortisol curve. So basically, they've lost a cortisol awakening response, which we know is an ominous sign because the body likes to maintain normalcy. So if you're losing that awakening response, it means sort of impending doom, as I always like to think of it. But the rest of the day, the cortisol curve is pretty normal. Let's go on to mini case 4. This is someone who is anxious during the day. They may have a stressful work environment. They may even have problems with blood sugar control. So which of these do you think it's associated with? The correct answer is C, but it could also be F. Because remember that it can be elevated, the cortisol can be elevated throughout the day, but you can also have peaks and troughs. And like in F, for example, it never really gets into the normal range, but it does go up and down. The last case, this is mini case 5. This is someone who is generally tired throughout the day. They may have problems with blood sugar, blood pressure. They can crave salty foods. And which one of these do you think is most likely associated with? It's kind of an unfair question because there's only one left, but the answer is E. So this is someone who is flat and remains flat throughout the day. This would be a person with stage 3 HP axis dysfunction. So now let's just move on, and I want to really start with this adrenal support or adrenal decision tree or HPA axis tree, where we're using our heuristic, right? Go to it and see how do you apply that to HPA axis dysfunction. You're going to, of course, do the same things you're used to doing. You're going to gather your information by looking at their medical history. You may use questionnaires. You're going to be looking at your anthropometrics and some of the biomarkers and the clinic indicators that you would find on physical exam. But really, I want to convince you of how important the history is, really obtaining a thorough history. And you're going to look for signs and symptoms that are associated with HPA axis dysfunction or adrenal dysfunction in the history. And of course, you're going to do a nutritional history and a nutritional status exam. Even though you may be ordering labs for this, I want you to really focus on gleaning as much as you can from your physical exam. You're going to do a thorough physical examination, and there's some patterns that we're going to focus on. And by the way, for thorough evaluation of these and discussion, I really need you to look at that pre-on-site lecture. Then you're going to populate your timeline. You're going to populate your matrix, and you're going to pick the areas of the matrix that you're going to focus on. And usually I suggest 2 to 3, no more than 3. And then you're going to tell the story to the patient. Now, I have to tell you, when I first started using the matrix and all the functional medicine tools, I found that telling the story was the hardest part for me to do. Initially, populating the matrix seemed a little tedious. But once I got it, once I understood that I was looking for those underlying dysfunctions, not necessarily whether someone had a disease, but what are the dysfunctions and where do they lie and how are they connected, then I realized this is a great tool. But now, how do I put myself out there and tell the story without being wrong, without getting embarrassed? And the fact is that this is personalized medicine, and we're there with our patients. We are with them one-on-one, and this is a two-way street. So there's no wrong answers. If at first the patient tells you, well, I don't think that's quite it, then they'll tell you exactly what they think it is or how they connected the dots. In many cases, at least in my experience, when I tell the story, patients' light bulb goes on and their eyes bulge and they say, wow, this is what I always believed, but no doctor ever told me that. Or if I told the doctor, they thought I was crazy. So I haven't mentioned that since. But telling the story is really important. This is where you're connecting the dots between everything that they told you, and you're letting them know that this is what you think it's going on. And if they forgot to mention something, they'll bring it up then. But this is really important because nobody has ever done this to the patient before. And they will be very thankful that you are doing it and helping them. And then, of course, you're going to order your lab evaluations. But I want you to really focus on just making that initial decision based on your clinical evaluation, which is going to be the history that you've taken, the physical exam that you've done. Now, let's just go through what are some of my sort of little pearls, because I basically really look for a detailed history and physical, and I'm going to look for those signs and symptoms. I'm going to try to find the root cause, knowing that sometimes you may have more than one. I do use questionnaires, and you have those in your toolkit. And on the first visit, I really try to address the chief complaint. Even if it is not exactly where I want to start, it is what brought the patient to me. And so I'm going to address it. But I will say, I also need you to do all these other things. And I start a nutritional assessment and nutrition and lifestyle evaluation and suggestions for treatment plan based on just my clinical evaluation. And then I'm going to order the other studies based on the matrix and the underlying imbalances that I've identified. But the physical exam becomes really important, and I look for clues as much as I can that are going to be associated with those underlying fundamental imbalances that we have in our matrix. And each time we're really looking for those modifiable lifestyle factors and how they relate to the areas of the matrix that you're going to focus on. And of course, we're always going to look for what are the root causes or the root cause. And we're going to listen to and look at our ATMs, our antecedents, triggers, and mediators to help us figure that out. And remember that patients are going to present in a variety of different ways. But it's really important then for us to try and figure out, how does that connect to these underlying functional imbalances? How can we use these functional medicine tools? So the G for gather, O for organize. We're organizing using these tools, using the history and physical, your timeline, your matrix, right? That all is going to help. And it's really important that you try and connect those dots to find out what is the underlying imbalances. And most of the time, the patient is really telling you. You just have to listen. And of course, we're taking an expanded history, not just looking at chief complaint and HPI, but we're also looking at their family history, their hobbies. What do they like to do for fun? Do they do anything for fun? How do they de-stress? And what's their support? All those things become extremely important. And you already know how to use your timeline as well as your matrix, because those are really the tools that help us then on that first visit be able to tell back the patient, right? You tell the story back. So, Mrs. Gonzalez, this is what I think you're telling me. This and this has happened in your history. This is what I find in your physical exam. This is what your body is telling me. This is what I think the problem is. And these are the labs I'm going to order. And I always tell my patients, the labs I'm going to order are either going to prove what I already suspect, or if they don't, then you and I are going to learn something together. But in any case, this is a relationship, the two of us. We're in this partnership together. And then once you've told the story back to the patient, you're going to order your labs, right? In this case, you may be ordering a 4-point or a 6-point salivary cortisol test, because with a 6-point, you get the cortisol awakening response. And then you're going to decide, are they in stage 1, are they in stage 2, or are they in stage 3? And you're going to then develop your treatment plan. And you could even start this on the first visit based on that. Let's focus just a few minutes on testing. I already covered this in a lot more detail on the pre-on-site lecture, but just so we're all on the same page, the best laboratory test for assessing your HPA axis is your 4-point or your 6-point cortisol test. You also get your free DHEA. And there's been lots of talk about looking at the urine, and does the urinary free cortisol, does it correlate with our salivary tests? I just need you to know that most of the literature we have is on salivary cortisol testing, whether you're doing the 4-point or the 6-point. Recently, we've had two studies. The last one was just in 2020 that looked at, dried urine, and is it really sort of a viable alternative for the measuring of cortisol and its metabolites? And in these two studies, it showed, yes, that the cortisol in the dried urine actually does correlate with the salivary cortisol. But I just need you to know that most of our studies are still on your 4-point or your 6-point salivary cortisol test. And I'm hoping that we'll have more studies looking at doing it in the urine, because sometimes it may be easier for a collection. But for the sakeness of being complete, as well as being sort of science-based, most of the literature is still on salivary. And the National Aeronautical Association, or NASA, does not put any man, woman, or woman in space without doing a 6-point salivary cortisol test, just in case you wanted that tidbit. Whenever you do instruct your patients to collect, though, their saliva, is extremely important that we've looked at anything that could interfere. So it's any topical steroids. They could be nasal sprays, they could be topical creams, they could be even eye drops. Really important, because that's also going to affect what our reading is. And so we want to make sure we've educated our patients. So taking all this information then, how do we personalize our approach? And by the way, I did a lot more talking about the cortisol awakening response in the pre-on-site lecture, so please listen to that as well. Well, we're really going to treat each patient as an individual, right? This is all about personalized medicine. And so I want you to think about exactly what are going to be your approaches. And before we do that, though, I need to discuss Cellier's general adaptation syndrome and what we often see with labs. And again, I did a lot more information on this on the pre-on-site lecture, but I want you to be aware of the 3 different stages, which you probably are already. So stage 1 is your arousal, your alarm phase. And that's where both cortisol and DHEA increase. And sometimes the cortisol could be high, but the DHEA may be normal. It all depends where you're catching the patient. In stage 2, think about as you're losing resiliency, or as Hans Selye said, it's the resistance phase or the early decompensation. But to me, it's where we're no longer as resilient as we used to be. Think of, we're losing our reserve, we're losing our resiliency. And in this case, cortisol still can be high, or is high, but the HEA starts to decrease. And it may be low normal, but is decreased. And that's a main sort of way to distinguish it from your stage 1. In stage 3, or your exhaustion phase, or your late decompensation, and that's been called adrenal fatigue in the past, but we now know that's really not true, because the adrenals don't become fatigued. It's more that the brain will downregulate or shut down the adrenals. So it's really all about exhaustion and late decompensation. And so in stage 3, both your cortisol and your DHEA is low, as we saw in some of the cases that I started with. To me, it's really important to look at causes, and this is one of the reasons why I copyrighted this list in 2012. But think of the ways in which, or the ways that have contributed to the way the patient is presenting. So what has happened in their life thus far for them to present the way they are? So you're going to really connect the dots between the symptoms the patient comes in with, even some of their past medical history or their prior diagnoses, and the areas of dysfunction, right? And you're going to use your matrix for that as well, but you're going to try and figure out how can I connect the dots between this and the different stages of HP axis dysfunction. And you're, of course, going to look at trauma, especially early life abuse or neglect. Think about allergies and sensitivities, dysbiosis or changes in the gut microbiota, but also digestive insufficiencies or excesses, and toxins. And then there's a multitude of toxins. It could be stress at work, stress in their personal life. It could be toxic relationships. It could be a hormone imbalance in some of the other hormones. And usually I think more upstream, like insulin resistance, for instance. It could be infections. It could be mitochondrial dysfunction, nutrient deficiencies. It could be an offset of some pharmaceuticals that they've been in or have been on, maybe not currently, but could be even previously. And also think about EMF and dirty electricity or oxidative stress. And it's not that we don't think about our single nucleotide polymorphisms and our genomics, but it's that they can contribute, but and often we have more than one cause. And don't forget about sleep, just getting 2 hours less of sleep each night, for instance. Let's say going from 8 hours to 6 hours over a week could cause HP axis dysfunction. So then when we're looking at our adrenal decision tree, we're going to try and decide which stage the patient falls into. And remember, with stage 1, cortisol is high, DHEA can be high, can be normal. Stage 2, cortisol is high, DHEA is low. And stage 3, both cortisol and DHEA are low. Now, to me, it's easier to approach HP axis dysfunction by trying to classify whether someone is hyper or hypocortisolemic. And so the next few slides are just a review of what I already covered on the pre-on-site lecture of just that, the hypercortisol disorders, and then we'll go through the low cortisol disorders. And what I'm trying to do is give you on some of the conditions that a patient may present with that are been associated with elevated cortisol. So think of your irritable bowel syndrome, especially your constipation predominant. Could be chronic stress or insomnia, chronic migraine, memory impairment, melancholic depression. And in this case, I really want to give you a sort of heads up about the difference between melancholic and atypical depression. And again, I discussed this in the pre-on-site lecture, but a melancholic depression is associated with a hypercortisol state, whereas an atypical depression is associated with a hypocortisol state. And there's been quite a bit of work on this. Golden Krauses are some of the investigators that have been prominent in this field, but there are others, and I have a list here for your references, some of the other conditions that have been associated with high HP axis activity or hypercortisolemic. So just to go through a little bit of a review, you're going to consider HP axis dysfunction and quite a few of diagnoses that patients will present to you. Think of them in chronic migraine, as well as your mood disorders and PCOS, for instance, as well as your irritable bowel syndrome, as I just mentioned. And also don't forget about what happens in those hypercortisolemic patients and the gut, because hypercortisol or elevated cortisol levels can cause quite a bit of damage to the gut. It can disrupt the barrier, increase the permeability. It can cause changes in the actual gut microbiome. So it's important that we're aware of that. And then let's go through now melancholic depression and what are some of the symptoms that someone with a melancholic depression would present with. I already mentioned that that's a hypercortisolemic depression where patients can complain usually of insomnia. They're more anxious. They have this dread of the future. They tend to have a loss of appetite. And these are very much an opposite to atypical depression, which I'll go through in just a little while. Also, too, your irritable bowel syndrome, constipation predominant, has been associated with elevated cortisol levels. And in the pre-on-site lecture, I talked quite a bit about cortisol and SSRIs, the fact that all SSRIs tested to present have all been shown to lower cortisol levels. I'm not disputing that they work on your serotonin, but in some cases, they may have more effect on the cortisol and the HPA axis and your cortisol curve. And I just need you to be aware of that perhaps one of the reasons why we have quite a bit of treatment-resistant depression may be because in some cases an SSRI was given when the cortisol curve was low. So if an SSRI is used in someone who has a hypocortisolemic type of depression, they may not have a good response because what's causing their depression can be their hypocortisol level. So just realize that when patients present to you with depression and they're already on an SSRI, SSRIs have been shown to lower cortisol levels. So whenever you have someone with a treatment-resistant depression, like someone who was diagnosed with depression and has been on an SSRI, consider that they really have an adrenal dysfunction or an HP axis dysfunction, and that what's happened is either they were hypercortisolemic and the lowering effect of the SSRI was not adequate, or maybe they had a hypocortisol type depression, in which case an SSRI may not really help. Now, some of you may know, I live part of the year in the Azores Islands. And this is a picture of my island. So the Azores are a group of 9 islands, and they're divided into 3 groups: the center group, the eastmost, and the westmost group. The center group is made up of 5 islands. The other 2 are made up of 2 islands each. In the center group, we have 5 islands. We have a center island, 2 islands on the south side, 2 islands on the north side. I live in that center island, which is St. George. And they're all volcanic, with the exception of 1 island that's not in my group. They're all 8 are volcanic eruptions. And I'm going to interject some pictures from there because this is a 2-hour lecture. And our brain can usually only hold attention for about 20 to 30 minutes. So we're going to be very left-brained here. But singing, pictures, changing sort of the background actually causes us to shift from left brain to right brain. So I'm taking that advantage, and I'm using lots of pictures from my island to help us sort of shift from left brain to right brain, because it will help us retain more information. At least that's my goal. So plus, one of the reasons I love showing pictures of my island is because it's the reason why I was able to sort of deal with and cure my HP axis dysfunction. And I'm hoping that you all have a special place that you can go to. And by the way, when I say my island, it's the island I'm from. I don't own the island. But I just wanted to show you. So St. George is the shape of a dragon, and it's called the Dragon Island when you look at it from above. And most of it, with the exception of some flatter areas, is above sea level. And we also have some areas where when the lava flowed, it actually flattened out, that I'll show you. But most people live along the side, and it's a very mountainous island. And I just wanted to show you that I live right up in here. So let's move on now. Now that we've shifted from left brain to right brain, let's move on to take a look at the low cortisol disorders and what it might be associated with and how patients with present. Now, when we're thinking about low cortisol disorders, let's try and link it to conditions that a patient may already come to you with, but also let's try and figure out how can it be associated with a condition that you may not have already known or some of our colleagues don't know. So I mentioned earlier that a hypercortisol depression is a melancholic depression, but a low cortisol depression is an atypical depression. And that's what I wanted to focus on right now, is to think of your atypical depression and how would patients present if they have an atypical depression. Because I said with a hypercortisolemic depression, they dread the future, they're more anxious. Whereas with an atypical depression, they're more tired, fatigued, they're hypersomnolent, they're hyperphasic. And I'll go through that in just a little while in addition. Other conditions besides atypical depression has been associated with low cortisol is seasonal affective disorder, postpartum depression. And remember, this is not 100%. In other words, you may have some postpartum depressions that may not be low cortisol, but in general, there's more association between a low and postpartum depression, a low cortisol state. Panic attacks can also be a low cortisol state, general anxiety disorder, your bipolar 2 disorder, and your chronic fatigue syndrome. With respect to chronic fatigue syndrome, initially we had some studies that showed it could be elevated cortisol, but above and beyond, most of the literature that we have is consistent with chronic fatigue syndrome being a low cortisol state. And here's some citations for you so you can go through them at your leisure. Here's another picture from my island. This is from the north side of the island. And I just had to interject this because I thought it was so interesting. I love exploring caves and little nooks and crannies. On the north side of the island, we have lots of caves and domes, and it's just an amazing place. And while I was exploring, I found this area that has, this is a natural tide pool. In the middle of this tide pool, there's this rock, and this rock is exactly in the shape of the island. And I just thought that was pretty amazing, and I had to include it. So now let's review how patients were going to present that come in with hypocortisol states. This is someone that can present with a panic disorder, with suicidality, with chronic fatigue syndrome. We know that there's higher rates in disadvantaged communities. We know that chronic fatigue syndrome is associated with high ACEs, particularly in women. So we're talking about the ACEs questionnaire, which again, I covered in the pre-on-site lecture. And we know that particularly both in men and women, but there's a few more studies done in women who had, adverse childhood experiences. As you follow them throughout the years, they may initially have had a hypercortisol state, but in adulthood, they're set up for a hypo. So it's almost like they were in this hypercortisol state for some time, and then there was a downregulation of the receptors. And so now they present in adulthood as a hypocortisol condition. We also know that flatter cortisol rates are associated with increased cardiovascular disease and cardiovascular disease mortality. So extremely important that we address that when we're seeing our patients. I mentioned this earlier, but now we're going through a review. So in atypical depression, patients present unlike the hypercortisolemic or melancholic depressions where they were more anxious. And in atypical depression, they're more lethargic, they're more fatigued, they're hypersomnic, and they're hyperphasic, which is the opposite of what you would see in a melancholic or hypercortisol depression. Let's review a few more things. And in particular, I want to go over adverse childhood experiences, early life stressors, and how that increases your risk for a flatter cortisol curve. And I mentioned that earlier. With PTSD, the initial studies look like it was more linked with or associated with a hypercortisol state. This has changed now because the more recent literature has shown that they can be, or they can present as hypercortisol, but they can also present as hypo or mixed. They may even present with a normal cortisol curve. And so it's really up to you to then take their history and figure out what has happened to them thus far. Now, I want to go through and start treatment. But again, I had to interject another picture just to balance our right brain, left brain. So as I said, my island is mostly a pretty mountainous island that most of the areas, at least where people live, are off or above sea level. But when the lava flowed and sort of erupted and then hit the ocean floor, it created some flat areas. And this is what my island is known for. It's unique. And they're called fajanges. And they're basically this flat area. In this case, this one has lots of natural tide pools, which in many cases they do. This is where I first learned how to swim. And some of them, patients or people live there year round, and others are more like summer homes. And although you can't see from here, in this area where you have all this volcanic rock, there's a series of these natural tide pools. And some of them are very shallow, like only 2 feet. And others, and of course, it would depend on whether it's high tide or low tide. And others will go up to 5 feet. And then there's one that goes up to 7. And that's how we learn how to swim. We would start in the very shallow and then graduate up. And once you could swim in the 7-foot deep pool, then it was time for the open ocean. I want to focus just a little bit on how do we treat the adrenal patient. And I want you to think about sort of complex versus complicated, because this has a lot to do with what we do in treating HP axis dysfunction. Now, an airplane is complicated. There's hundreds of details involved, and you have its planning and its execution, but the outcomes are predictable if the inputs are consistent. Human beings and our diseases, though, we're pretty complex, right? There's many conditions that can emerge from a single cause, and individuals have their own pathways towards their diagnosis. Outcomes are not predictable. Everything is connected to everything else. And this was something that Dr. Jeff Bland brought out in his latest book, which is called The Disease Delusion. The Disease Delusion. And I thought that the way that he described chronic disease and the characteristics that distinguish them have a lot to do with how we look at HP axis dysfunction. And so what he said is that first, chronic illnesses do not heal themselves. In other words, they're not self-limiting. Number two, chronic illnesses tend to get worse over time. And number three, they don't have a single cause. So in other words, a chronic disease doesn't emerge from one single point that we can point to. But in general, they're multifactorial. There's different causes that give rise through it. Number four, chronic illnesses tend to have complex system profiles. That is, there's numerous complaints that can be involved. So to me, I feel this is really true when you're looking at HP axis dysfunction, and we have to sort of connect the dots between all of those to get to the root cause. And my approach has always been to really start with your lifestyle modification, right? To really look at that bottom part of the matrix, and how is their sleep? How are they moving? Are they resting? What's their stress like? And what are their coping skills? And what is their relationships like? And what can we do about it? And of course, we're going to also focus on nutrition and making sure that they're eating 10 to 12 servings of fruits and vegetables, and predominantly the low glycemic load fruits, for example, that it's phytonutriently dense and that it's colorful. And then we're going to add our supplements or our nutraceuticals, as well as our adaptogens and our hormone replacement when needed. But I want to go through exactly how do I start and where do I feel we should start? Because to me, I address sort of the treatment of adrenal dysfunction much the same way as the blue zones showed that those people that lived in the blue zones to over 100, that there were some characteristics they had in common. And I want you to think about those when we're developing a treatment protocol for our patients. So the 5 areas of the world, of course, they're part of the blue zones, are Loma Linda, California, Ikata, Greece, Sardinia, Okinawa, and Costa Rica. And when they looked at the studies from all those areas, they found that there were 7 factors that they all had in common. And these are the 7 factors that I find are crucial for treating HP axis dysfunction. And number 1 was that they all had strong family support. And some of them, they lost their families, like, for example, in Okinawa with a war, but they formed another family. In other words, it doesn't have to be a biological family. We can form a family. Number 2, they all had a real strong sense of support. A strong sense of purpose in their life. Number 3, they had a diet that was low in processed foods, and it was high in antioxidants, even in some cases like Ikata, Greece, if the antioxidants were coming from wine. They all had a strong faith, sometimes a faith in themselves and a faith in a higher power. They all had an active social life. Number 6, they all engaged in moderate to vigorous exercise. And number 7, sleep. They all slept well or they took naps. And I feel like these are the areas that we want to really focus on with our patients. Of course, we have more tools in our toolkit, but these to me lay the foundation. And this is why I start with overall lifestyle changes. So we're now in the initiate, the go to it. So the I for initiate. And we're going to really work on that area, right on the bottom part of our matrix, those modifiable lifestyle factors. And I want to sort of divide them, divide them as they're divided up in the matrix. And I'm going to approach them in the same way. It's in the same chronological order. So first we're going to talk about sleep, and then movement, nutrition, stress, relationships, and sort of the mental, emotional, psychospiritual piece. Let's start with sleep, because sleep is crucial. Sleep is anabolic. So cortisol and elevated levels of cortisol is catabolic. But to counteract that, we really need to work on sleep, because sleep is very anabolic. And we have quite a few studies now looking at sleep. I already mentioned earlier that even sleeping just 2 hours less a night, right, on 7 consecutive nights, could raise your serum cortisol levels between 50 and 80%. So really think about how well patients are sleeping, and are they able to get to sleep? Are they able to stay asleep? And how crucial that is. Next, let's look at movement. And when we're talking about movement, I don't like to say exercise because sometimes exercise can be a dirty word. But if we talk about movement, then I feel like then we're sort of all on the same page. And we're going to develop the movement based on which stage of HPA axis dysfunction the patient is, right? If they're in stage 1, you might do more intense movement. If they're in stage 3 or late stage 2, you might suggest more yoga type movements or Tai Chi or Qigong. But in any case, you want to be aware that we have studies on both, right? We know that exercise increases endorphin levels, it improves mood, it improves circulation, reduces anxiety, and improves quality of sleep, can reduce depression, for instance. And so we're going to have to tailor it based on how our patients are presenting. Just like in this picture, the person who's over here throwing in the corn is doing exercise, but it's more slow, rhythmic. Whereas the one who's pushing the plow or even the horse, they're doing a little bit harder work. The person who's leading the horse, well, maybe not so. And this is exactly what we need to assess in our patients, because I find that myself, I don't like to go to a gym. Some of my patients don't either. But I love to move. I love to sort of be outdoors. I love to hoe my own corn and plant my own corn. So it's really important that we assess where our patients are at and we devise a plan for them that maybe won't even seem like exercise necessarily. It's movement and it's doing something that they like to do. We know that, for example, just even moderate and low intensity can be effective when they're done for 15 minutes. The study was looking at 15 and 30 minutes a day, 3 times a week, and how the impact on the hypothalamic pituitary adrenal axis and physiological activity to stress was much diminished. This was a 10-week study. But we also have studies on just the 7-minute miracle, right? The 7-minute workout. This is a high intensity interval training. Now, for your patients that are able to tolerate it, this is a great way to approach them. But for those who are not, you can just send them on leisurely walks. I love this trail, for instance, where I have the mountains on one side and the ocean on another. And it's just really nice being out there. I also like to do hikes, and I particularly like to hike the top of the mountain, for instance, in my island, where on the one side here, I can look on the north side of the island and see the surrounding islands. And on the other side, I'm looking out at the south side. Again, I have 2 other islands. And to me, being outdoors is just very healing. We have studies about being in nature and the awe that we get from finding awe in nature. But it's really up to us to sort of gauge and decide where our patients are at. We know yoga can be really important as well. This is looking at Iyengar yoga, which is focusing more on precision of movements, but it is a type of hatha yoga. So we will need to devise that for our patients and show them how doing yoga, for instance, can lower your salivary cortisol levels. And this was looking at women who were breast cancer survivors. So lots and lots of literature. And I'm sort of a person who moves to the beat of my own drum. So I love doing yoga outdoors. It's up to us to try and figure out what motivates patients and how can we get them to do what we want to do in a way that it doesn't seem like a lot of work, right? It's all about what do they like and how can we present it to them. Let's move on to nutrition. Now with nutrition, this is one of my favorite areas because there is so much that we can do with food, and we know that food talks to our DNA, whether we're eating an anti-inflammatory food, which will create an anti-inflammatory reaction, or we're doing a more inflammatory type of food, which can lead to more inflammation. But in any case, it's really important that we look at sort of the regular meals and what's the glycemic load. And sometimes when someone is having hypoglycemic episodes, they may need to eat up to 5 or 6 meals per day. Focus on chewing, chew at least 30 times before swallowing. And it's not about chewing a little bit, swallowing, and then continue to chew and counting. It's chewing 30 times and then swallowing. And then we're going to need to increase fiber and avoid stimulants. Now, in particular, when we're talking about fiber, we want to focus on two types of fiber, both insoluble and soluble fiber. We know that with soluble fiber, it can help stabilize the cortisol, right, through eating regularly, but it also can avoid some of those cortisol spikes. Soluble fiber can do that too, to some degree, but soluble fiber is going to be working on the gut microbiota and increasing the production of butyrate, which is going to prevent or help repair that increased permeability due to high cortisol levels. So it's really important that we consider both types of fiber. And also too, the phytonutrient spectrum. And I want patients to eat 2 to 3 colors each day. Usually it's always green, and then it can be purple or orange or red or yellow, but really focusing on eating like the rainbow. And we have, our food plans are going to help us identify that, as well as identify the different types of phytonutrients that correspond to each color and the rainbow, so to speak. Now, the microbiota is extremely important, and I couldn't talk about treatment, the HPA axis, without talking about the gut microbiota. And then we know that it's imbalances in the HPA axis that can cause changes in the intestinal microbes. And again, if we intervene in the right way with fiber, for example, with all those phytonutrients with different color, it can really do a lot to heal the gut and affect the HPA axis, because, we often think of the gut as the second brain, but sometimes I think it's really the first brain, because it's a two-way communication system, but there are more ways that the gut communicates with the brain than vice versa. And more, we're having studies looking at how microbial factors in the gut microbiota itself can affect the HPA axis. This study, for example, was looking at the growth of commensal bacteria, particularly lactobacilli, that can confer increased emotional resiliency when we're under stress. Isn't that amazing? And fermented foods. We know that fermented foods can actually help improve social anxiety. And whenever I talk about fermented foods, I often get a little bit of a resistance from some of my fellow colleagues, because they'll say, well, but fermented foods are high histamine, and many of these HPA dysfunction patients, have a lot of food sensitivities. Yes, that's true. But it all depends what you ferment your food with. So I teach my patients, and I do this myself, to ferment their own foods. And I have them fermented with Lactobacillus plantarum, because Lactobacillus plantarum is a probiotic, but it can also be used to ferment your foods, whether you're doing kefir or yogurt or fermented vegetables, for instance. And Lactobacillus plantarum has a unique capability to digest histamine and oxalates. And so you're using something that is going to help digest histamine, so it won't so much be a problem. The other thing is, I really want to encourage patients to grow their own food as much as possible. Now, not everybody has that option, but I've even taught patients to do it in a planter, just like you would have a plant, right? You can do kale in a little planter pot. And I feel very lucky that when I'm in the Azores, I have, a great garden. When I'm in the States, not so much. I'm in an apartment and I'm limited. But in any case, it's all about the intention and what you can do with it. And really trying to work the land as well and grow your own food just makes it so much easier. And to try and really encourage our patients to do that as much as possible. Let's move on to stress. And sometimes we cannot avoid stressful situations. I wish we could, but in some cases we cannot. But we can arm our patients with more coping mechanisms, with more resiliency skills, with ways to offset the effect of the stress on our own body and our physiology and psychology. And I really love the work of Robert Sapolsky. And he talked about the stress response and how, and this is in his book, Stress-Related Disease and Emotional Regulation. He talked about how overwhelmingly, it's the psychological rather than physiological stress that has the highest capacity to elevate and maintain the stress response chronically, which then can cause diseases. So I just wanted you to be aware of the fact that, we're all faced with stress, but let's see, how can we help our patients restore, right? Helping them rest, whether it's physiological, emotional, mental, and to avoid stressful situations as much as possible, and to just really focus on, taking some pleasure every day and putting some time aside for that. Because, the fight or flight or fright or freeze is automatic. So relaxation really has to be learned and practiced, and nobody is born knowing. None of us are. But I want to take a few minutes to focus on something else, and that is that more and more in the last few years, it's come into light that we don't necessarily have to go into the fight, flight, freeze pattern or fright, but that we can also draw in this other sort of pathway, which is a tend and befriend. And the tend and befriend pattern draws upon sort of the attachment caregiving system. And it's thought to be a combination of oxytocin as well as some other opioid or peptide hormones or mechanisms that be responsible for this. But it is now shown, and there's quite a few studies on this. And I just wanted to mention, according to Shelley Taylor is a psychologist. She says that it seems to be more common in females, and that maybe sort of we've evolved this to try and survive not just ourselves, but to protect our offsprings. And so the tend is really this nurturing in a way that reduces our neuroendocrine responses that can comprise our health. And befriend is more where you create, you maintain, you can utilize social groups to reduce the risk of harm and also to manage our stressful conditions. So I just wanted you to be aware of that, and that the literature is available. And I think sometimes that if we know this, and we talk to this with our patients, maybe just knowing, just like sort of the power of intention, we can go there. In other words, if we tell our patients, there's also this state of tend and befriend, and there's lots of literature around this. It was actually a strategy that was initially developed to help nurses increase their ability to sort of channel stressful situations into personal growth situations. And even if we're not nurses, we can utilize this. Plus, whether you've been aware of this or not, this has actually been used in the intensive care unit, where if you just sort of tell patients that there's these other pathways available, that they can go into this tend and befriend stage, that it is more likely to happen. And I have a few more studies there for you. Let's talk about breath and the power of breath. And I really like the work of Marty Rossman, who is an MD in Mill Valley in California, and he talks about the 6-2-6-2 breath, where you inhale for the count of 6, the belly breath, hold for 2, exhale for 6, hold for 2, and repeat. But there's also the 4-7-8 breathing, where you inhale through your nose for 4 seconds, you hold your breath for 7 seconds, and then you exhale through your mouth for 8 seconds. And it's really all about what works best for your patients and helping them decide which is more adaptable to what they're used to doing. But I have to tell you that the breath is very, very powerful. And what about laughter? This is a study from 2016 looking at the effects of laughter on patients who were undergoing hemodialysis. This was a 4-week program. They had weekly 60-minute sessions. And you know that just laughing for 15 seconds actually showed improvements in their mood and their symptoms and their quality of social interaction, and it actually improves some of their limitations. So just having patients watch a funny movie, or even just laughing, if there's just laugh out of the blue, amazing what that can do. Singing. A single hour of singing was associated with increases in positive affect, decreases in negative affect, and decrease in cortisol. Now, some people are blessed with the ability to sing. I'm not one of those, but I love listening to music. And we have studies showing the same thing, that listening to music can also lower your cortisol levels. And then I want to talk about the power of just your smile. I translated this from Pedro Chagas Freitas, but I just wanted to read what he says. He says, the word smile makes me smile. The word smile makes everyone smile in reality. Experiment with saying smile and check yourself. You will be smiling too. This is what I do when I am less than happy. I stand in front of the mirror and say the word smile, and in an instant, I am smiling. And it seems simple, but sometimes not so simple. But to me, it's all about having so many different tools in your toolkit that we can use to affect our patients. Drumming, this is a study on group drumming, showing a positive psychological benefit from community-based music making. And this is an amazing study. They actually looked at levels of cytokines, interleukin-4, interleukin-6, tumor necrosis factor, cortisol levels, and we saw a decrease in cortisol levels and an increase in antioxidant capacity and a decrease in the inflammatory cytokines. Pretty amazing. Let's move on to relationships. And when we talk about relationships, I want you to focus on or even consider relationships with the self, not just relationships with others, but even do they have a relationship with themselves, as well as friendships and community, right? We want to make sure that they have a relationship with self, that they have a relationship with others, even just with their environment. You know, this is me using my chipper because it's a one way that helps me feel powerful. It feels like I can do something. And then, of course, you know, relationships with others and community involvement where you're actually a part of the community. This is our Pentecost celebration, or whether you're just a bystander, you're watching. In any case, extremely important that we discuss this and give our patients those type of tools, or we investigate what's going on with them. And what about pets? You know, I'm always really impressed how loving a relationship my two kitties have. It's a male and a female. And we have studies looking at small animals as well as large animals, such as horses. This is with I-Ching here, who is amazing, the literature out there with helping decrease cortisol levels, whether it's large animals or small animals. Religious participation. If someone already has a religious group that they belong to, just want you to be aware that there is patients who had a religious participation, they had healthier cortisol slopes, even when they did a 10-year follow-up study. So pretty amazing. And it doesn't mean that if patients don't belong to a religious group that they necessarily need to, but just know that if they do, this is an avenue that you can utilize. Let's go through now our mental, emotional, and spiritual. First, at the top of the list, you want to make sure that you're addressing trauma if there's any there. Extremely important that we address that. And in most of my patients, we're usually able to discuss it on the first visit. Sometimes some patients may not feel comfortable, so they may only have sort of limited answers, but usually by the second visit, they're ready and they want to be able to talk to you because you may be the first person that talked about it to them. I want you to focus on some of the literature, especially books that have really brought me the most tools and that I use the most. This is the work of Reshma Medican. It's called My Grandmother's Hands, and it's about racialized trauma and the pathway to really mending our hearts and our bodies. He's amazing. He's got several books out. I've used this work quite a bit because this is really a way that we can actually go back and we can heal trauma, and whether it's racialized trauma or otherwise. But now that we're talking about racialized trauma, I want you to really focus also on some of the other literature out there. This is looking at what happened to the Native Americans and the Alaskan Natives, and the fact that we can have racialized trauma that skips a generation. In other words, we can have the grandchildren today experiencing the same effects of what happened to their grandparents, for instance. And we know that sometimes there's some culturally protective factors, such as maintenance of identity, for example, that can buffer that impact. But sometimes we're dealing with groups where some of those culturally protective factors may have been withdrawn. And so we want to make sure that we're working on that. I couldn't talk about trauma and intergenerational trauma without mentioning the work of Rachel Yehuda. She's looked at Holocaust survivors and the epigenetic effects of trauma, and she's found that psychophysiological trauma may have intergenerational effects. There's many different people looking at this. She's one of the prominent in the field. And then I want to also mention the work of Stephen Porges and the polyvagal theory. And the polyvagal theory basically proposes that there's changes in psychological state that then can influence behavior. And he was sort of the first person that mentioned that the vagus nerve has actually two divisions, right? A dorsal and a ventral. And he's really talking about how changes in that dorsal and ventral branch, if they're not sort of balanced, someone can present more like they're in a fight or flight or fright stage. Now, his work was really important. And in particular, I also like what Stanley Rosenberg did with his work. And so Stanley Rosenberg sort of took Stephen Porges' discoveries to the next level. And he talked about how can you access the healing power of the vagus nerve. And so he wrote a book that talks just about that. And in his book, he's got several different movement exercises. You're not actually exercising, but they're eye movements that you can do to try and balance the ventral and the dorsal branch of the vagus nerve, because all of our cranial nerves have some fibers that run with other cranial nerves. So vagus nerve being cranial nerve 10. The other person I want to particularly mention is Bethel van der Kolk and his book, The Body Keeps a Score. And he really talks about how we have sort of memory or biological memory or cellular memory, and that sometimes when we're doing cognitive behavioral therapy on trauma, we're still in that same loop. And so you have to do something that will actually help you create new neuronal pathways. And he describes this very well in his book, The Body Keeps a Score. Now, the most amazing thing about Bethel van der Kolk is that he's also a prolific writer and an investigator. And he's been involved in some way, shape, or form in most of the literature or the articles that have been published on trauma. And he really does a great way of sort of combining all of that in his book, The Body Keeps a Score. Also, Sheila Wise-Rowe, Healing Racial Trauma, and The Road to Resilience. I love her work. And many of these different books have actually a lot of commonalities among them. Mark Woolen talks about It Didn't Start With You. He mentions Rachel Yehuda. He's not an investigator, he's a writer, but he really sort of put everything together as to how this intergenerational trauma works. And, different people learn at different rates, and sometimes they learn from the way things are written in a specific way. And so I like having long lists, because then I can see what is more appropriate for each patient. Another tool sort of in my toolkit for dealing with trauma is looking at heart rate variability. And you can do this just for stress in general, but heart rate variability measures the beat-to-beat fluctuations in your heart rate. So in between each beat of your heart. And diaphragmatic breathing, for example, where you're doing the 6-2-6-2 or you're doing the 4-7-8 breathing, has been shown to really increase your heart rate variability, because the longer you are in stress mode, the less variability, heart rate variability you have. And there's lots of studies looking at salivary cortisol, and it's particularly in patients with hypercortisolemic states, and then increasing their heart rate variability, and that being associated with a decrease in salivary cortisol. This is again looking at heart rate variability in psychiatric disorders, and this was found. They were looking at the sort of trauma and can heart rate variability be used? And yes, this is what the study showed. It's pretty amazing just how much you can do with increasing your heart rate variability. It's also been looked at in women that are victims of sexual abuse, and we saw that over time that there was a change in their pattern, the heart rate variability, and improved in sexual arousal and orgasm, for example. Now, I've talked about religion before, but I wanted to mention it here because I thought that this is really amazing, some of the studies on looking at religious practices as a mitigating factor in coping with some of the sequelae of racism and discrimination. And then this is looking at patients, actually these were Black Americans, where they found that religious involvement was a significant factor in dealing with the harmful effects of discrimination, as well as also learning some and obtaining or increasing their resiliency.